Hello, and welcome to Monitoring Virtual Summit. I'm Anuja Vaidya, Senior Editor and Special Events Lead at Xtelligent Healthcare Media and moderator of today's session, Addressing Digital Health Literacy Issues Within Vulnerable Populations. Before moving on, I'd like to thank our sponsors, CareSignal, Current Health, and Tropolo. Today's presentation will be a panel discussion, followed by a question and answer segment. Audience members can submit questions at any time during the session using the Q&A box on the left-hand side of the screen. A recording of the session will be made available later this week. Today's session will play via your computer speakers. We do not have a dial-in for today's presentation. If you experience technical difficulties, please try refreshing your browser. For all other technical matters or difficulties, click the help icon at the bottom of the screen. Now, I'd like to introduce our panelists for today's discussion. Dr. Roxana Cruz, Director of Medical and Clinical Affairs at the Texas Association of Community Health Centers. Evan Harmon, System Remote Patient Monitoring Manager at Baptist Health System. Shireen Schlegel, Executive Director, Telehealth Clinical Operations at Providence Health. And Jared Antczak, Chief Digital Officer at Sanford Health. Thank you all so much for being here. Now let's begin today's discussion. So let's jump right in. What are some of the key digital health literacy issues facing vulnerable populations today? Roxana and Jared, let's hear from you both first. Roxana, maybe you could kick things off.
Thank you. And thank you for the invitation to be with you today. So I represent the Texas Association of Community Health Centers. Community health centers are typically the federally qualified health centers where we serve primarily populations made underserved over not just a couple of one generation, but many times many generations. So I just want to call that out because when we talk about the key digital health literacy issues that are facing those populations, we're talking about rural, particularly here in Texas. We're talking about the elderly. We're talking about historically underrepresented and underserved. So those key issues in my mind, I'd sort of divide them into the digital divide, which is a big chunk of a big bucket that is, in my estimation, has to do with the infrastructure of digital access. So that digital access can be used, including broadband, right? And access to devices and access to the understanding of how those devices can best be used for improving health outcomes. So I think one piece is the digital divide. The other piece is the workflows that need to be incorporated into the continuum of care, and thinking more of the continuum of care as something much broader than just your four walls in your health center or in your office. It's really thinking beyond that. It's thinking about who your partners are and how you can use technology to bridge those gaps within the continuum. And then lastly, understanding what options are available and then improving and engaging your partners. So your partners are internal within your organizations, within your clinics and offices, health systems, but then your external partners as well. And really having them have a deeper understanding about the importance of improving health literacy, not just for one individual patient, but really at a level of population health level, which will ultimately affect the health system and can potentially improve quality of care, as well as lead to value-based care and success in value-based care. Those are my thoughts.
Absolutely. Absolutely. Thank you so much, Roxana. It really is the missing link, so to speak. Jared, what do you see as some of the key digital health literacy issues sort of affecting underserved populations?
Yeah, and thank you also for the invitation to join. I resonate a lot with Dr. Cruz's comments because Sanford Health, as the largest rural health system in the United States, we have a really unique perspective when it comes to some of the unique challenges and opportunities that we have with the patients that we serve. So approximately 2/3 of the patients that we see live in rural communities. The vast majority of counties that Sanford Health serves across the upper rural Midwest are federally designated provider shortage areas. And so people living in these communities likely have fewer resources, including access to care. At the same time, they continue to experience higher rates of poverty, things like food insecurity, chronic disease, which often lead to other poor health outcomes. And during the pandemic, many of those challenges were exacerbated. So, here in the upper Midwest, it's not uncommon for some of our patients to travel sometimes 3 to 4 hours just to get to the nearest doctor's office. And unfortunately, for many, that means taking time off work, finding childcare or reliable transportation just to make that journey, which can be a barrier for many people to get the care that they need in time to make a difference. So we know that postponing preventative care can really result in other negative health outcomes. And so we need to make it easy for them to be able to do the right thing for our patients. The potential for virtual tools to bring care closer to home or even in the home can really be life-changing or even life-saving for some of the people in these communities. So when I think about vulnerable populations, that's very much close to home for the folks that Sanford has the privilege of serving. Digital literacy, is interesting because that refers to the level of comfort and confidence that people have in using technology and engaging in a digital experience. It can be challenging for some people to download, register, navigate a digital solution, potentially connect things like remote patient monitoring devices if they're not technically savvy. And digital literacy also includes things like language barriers or accessibility accommodations, cognitive limitations. And it's just one component of what many refer to as digital equity. Digital equity is a social determinant of health. Digital literacy is one component of digital equity, but other components include things like internet access. A lot of the patients that we serve might not have technological connectivity through high-speed internet, whether it's through broadband or cellular. It also includes things like device availability. Many people may not have access in these vulnerable communities to smartphones or tablets or laptops or desktops with webcams. So how do we remove those points of friction and allow people to engage in some of these digital offerings that we can provide?
Absolutely. And one of those digital offerings that, would be very beneficial to provide is, of course, remote patient monitoring, and kind of having these issues really, limits people from experiencing its benefits. So, Shireen, I'd love to hear from you on, how these digital health literacy issues really impact RPM use within underserved communities. And then we can hear from Evan as well.
Absolutely. I'm happy to share from my perspective. In telehealth, we have multiple different programs that we've offered throughout our 7-state footprint on the West Coast here in Providence. I want to call out a specific use case, which is our COVID home monitoring program. We launched this in the throes of COVID, March of 2020, and today we've served over 30,000 patients. And I'm really proud of the fact that we were very intentional in working with our various partners in our communities to really make sure we had, to Evan's point, Jared, to Jared's point, you have to make sure patients have the technology that is easy for them to use. We chose some really low-tech standard thermometer, pulse ox. We made sure that we had interpreters with a capacity of over 200 different languages available to be able to work with our patients. And then also from our EMR and the technology we utilize to communicate with patients in the home, we were able to make sure that was translated into 14 different languages, just from the standpoint of being able to read. And something that we found that was really important was the role of our nurses. So in this program, we were able to safely keep patients out of the hospital, monitor them at home with their COVID symptoms, and then when necessary, we would escalate them to a higher level of care. And our nurses were pivotal in making sure that they understood their education. We connected via video or phone with patients, with interpreters. And also, to Jared's point, if patients didn't have a smartphone, that was okay. We were able to work with them to report their vital signs over a telephone. Sometimes other family members had a smartphone that we were able to use. And so it's really important to have a plan as you're implementing these programs that really addresses the patient's needs. You have to know where they're coming from, what's available in their environment. And I'm really proud of the fact that we were able to successfully and continue to do that with our COVID home monitoring program.
Absolutely. You really have to sort of meet the patients where they are at their level, open up modalities that work for them, essentially. Great. Evan, I'd love to hear from you. How does digital health literacy issues impact RPM use?
Absolutely. So if you're having those challenges, for instance, with what Jared mentioned, connectivity, that is something that really could lead to you not being able to have that patient use remote patient monitoring technology at all, which then sort of puts that barrier in there and creates that digital sense that can adopt the technology. With some of the challenges that were mentioned, you could have low engagement on RPM. So I think it really boils down to the fact that you need to be a problem solver. You need to work with, as indicated by the other folks, your vendor partners, to come up with solutions to these challenges. You certainly can't solve every single problem, but the things that you can solve for, you really need to put some focus into that space. So with the language barrier issues, for example, within our tablets that we supply our patients, working with our vendor partners to make sure that the preferred language for that patient is made available with some of the instructions and with some of the prompts that are embedded within that software. So that's one really important way, I think. And I really liked the comments about the low tech, using solutions that really integrate right into that patient's life, kind of that Internet of Things sort of concept, a wearable that really is going to be easy to use, and software that is also low touch and easy to use as well.
Absolutely. And Evan, I think you provided a great segue to my next question, which is essentially strategies. What can we do to really alleviate these, digital health literacy issues, so that these vulnerable communities can access the full breadth of the benefits that RPM can offer? So what are some ways in which Baptist Health System is working to address these issues?
Absolutely. So when you have individuals with low digital literacy may be concerned or scared of the technology, using vendor partners that have a technical arm that can assist those patients when they have questions. We are fortunate that our clinical command center has a technical arm within it that can help patients when they are struggling with using the technology, and they can do that virtually. We're also very fortunate to have a home care program where folks can go into the home and explain to the patient how to use the technology if they're struggling with it, or if they lack a support system to assist them with that tech. Also, along the same lines of translation services, we use translation services to help close some of those gaps as we're working through any of those particular challenges. At Baptist, we provide RPM in two different ways. So we provide it via home care, and we provide it via specialty outpatient clinics, like our heart failure clinic, for example. So we try to make sure that when we're having conversations with our patients regarding this technology, that it's not just a conversation, that we're opening the kit, that we're pulling it out, and we're pulling the technology out and walking through that process with them. We really spend intentional time in the course of that clinic visit, or in the beginning stages of that home care visit, where they get that remote patient monitoring technology, and we really talk through things and make sure that we've addressed all the questions and concerns that the patient and the caregiver have, to close any gaps where they might be concerned, or they might have a little bit of anxiety about the technology or about what the program is going to be. If we find that maybe a patient leaves our clinic with one of our devices and they haven't set it up or activated it, doing that intentional check-in with that patient to say, hey, what's going on? Why haven't you activated it? Do we need to send someone into the home to assist you? Do we need to get someone from our command center to give you a call and help you through this process? So I'll yield back a little bit and let some others weigh in on this, because I think there's so many different cool strategies. We certainly have others, but I want to give some of our colleagues the chance to comment on that as well.
Absolutely. Let's jump to Jared. I'd love to hear what Sanford Health is doing to kind of really address these issues.
Yeah, I think, one of the core things that we're actively doing at Sanford Health, just to take a step back a little bit and just talk a little bit about our process, is making sure that we're always starting with the problem, defining the problem so that we're matching it with the right solution. I think sometimes in healthcare, too often we start with the solution. We see a demo from a vendor, we become excited about all the bells and whistles, and then we work backwards to try to identify a potential problem that it can solve. Instead, we try to start with the problem to ensure that we're really solving the right things, So, from a design thinking standpoint, we want to build the right things and then build the things right. So on the patient or the consumer side, what that looks like is, identifying what are the points of friction that our patients are experiencing. What are their underserved needs or their jobs to be done? What are their preferences and expectations? What are their intrinsic motives and, the incentives that they have to take a particular action? And then similarly, on the business or the clinician side, what organizational objectives and outcomes are we really trying to achieve? What's the most important areas that we need to focus on? And then what key results or metrics or indicators will determine success? Once we've determined those questions, we know what we're looking for in a solution, and that really helps to improve the likelihood that we're going to have success in picking the right solutions. More tactically, though, I loved some of the examples that Evan shared, just in terms of pulling the technology out of the box and helping patients understand how to use them. That's something that we're looking at and exploring as well, to make sure that we're setting our patients up for success with different digital technologies or remote patient monitoring. So, one of the things we do or we're looking at is for patients who are admitted in our hospitals or long-term care facilities who might qualify for early discharge with a remote patient monitoring device, before sending them out the door, we explore whether they have a compatible mobile device or laptop available. And if not, then possibly providing a loaner device to them if necessary. Where possible, we can look at connecting their devices, their remote patient monitoring devices to their laptops or to their mobile devices while they're still in our facilities, and then show them how to use them while we have their undivided attention. So this, see one, do one kind of approach really helps to demystify the experience and helps to remove some of the fear of the unknown when it comes to unfamiliar technologies, and helps to increase that digital literacy while we have their attention, and ends up resulting in better outcomes in the end in terms of adoption and utilization of those things.
Absolutely. And I'd love to throw it over to Roxana now to talk a little bit about addressing digital health literacy issues, but in low resource healthcare settings. How can these facilities that are sort of lower resource really work to mitigate these issues and
Thank
then
you.
advance RPM use?
Thank you. So I think that it's a huge challenge, but it doesn't mean it can't be done. It means that we have to be creative, and we do have to think outside the box. So in health center settings, it is true that we have to not just train the staff because we work in a team-based approach. We have to also train the patients and then make them, as several of the speakers already mentioned, you have to make them comfortable, meet them where they are, know what they have available in their own homes and in their own environments, and then try to bridge that and meet them there. And then further it, of course, after you assess the patient and assess what their needs are as well as what they have access to, then either provide some increase the access, and in our health centers, what we've been, even in particular during COVID, we had to become very creative. And one example is that we learned to identify where the patient could seek out Wi-Fi without a cost to the patient. So we would indicate to the patient, this is where you can go and you can do virtual visits at this site. Now, if they don't have a device, we became creative, and there were several health centers that had devices, either laptops. Usually it was going to be more of a pad that they would clean and then provide to the patient through a window while the patient is in the parking lot. So the patient did not have to come in and be potentially exposed to an ill person, or they themselves would not be exposing others. So that was very simple, but just creatively, right? So those were some rudimentary examples. More on a broader scale, what we have also done through the Texas Association is seek out some basic funding for our health centers, because it is true that remote patient monitoring is not available to be reimbursed at this time. But our hope is that if we can do some pilots and some demonstration projects, that we can actually move that forward through to legislators as well as managed care organizations. And in the meantime, there is definitely the difference. It doesn't have to be a remote patient monitoring device. It can actually be a remote patient monitoring service or program, which many of you may be familiar with, and is very effective and low resource. So it is deviceless. So we are doing a pilot with that. And then we're also, in the meantime, as we use the pilot, during that bridge to get to reduce the digital divide for our patients. We're also teaching them about how and when to use remote patient monitoring, not just services, but also devices, because we do believe that that will be reimbursed in the future. So I'll yield to somebody else.
Absolutely. Well, I'd like to also kind of talk about another aspect of these remote patient monitoring programs, particularly when you sort of have a larger health system and you're trying to scale these efforts. So Shireen, coming from Providence, obviously you have lots of facilities across states. What does it look like to really scale these efforts in different areas, in different states where maybe the, digital health literacy issues are not, a one-for-one, it kind of changes depending on where you are?
Yeah, you bet. I appreciate the question. We worked really intentionally, again, going back to that experience with COVID home monitoring program. We found that for our operational workflows, it was very challenging to be able to identify across 90 different sites, at the time, 6 different states, which interpreter services to use. We ended up making that a lot easier on ourselves and contracted with one entity. So it was a consistent interpreter service that we had available, again, over 200 languages. And then we also made sure within our EMR, when we went live at various sites, we looked to make sure that we had the predominant speaking languages for that area available, certainly with our interpreters, but we also, as I mentioned, translated our EMR materials, so discharge education, things like that, into their predominant languages. We certainly couldn't get them all. And then when it comes to, again, scaling, largely making sure that all of our workflows accounted for and, relying on a checklist to make sure we're addressing the patient's ability to be able to participate in the program, whether it's a language barrier or having the digital competency. Like I said earlier, they may not have had a smartphone, but we worked very closely with a family member that we knew might have had a smartphone. And if nobody had a smartphone, we worked with them to be able to communicate over telephone. So I would say additionally beyond that, outside of the COVID home monitoring program, as a large organization, making sure that our EMR tools are also available for folks. And you think about the ability of when patients are leaving a clinic, making sure they have access, if able, to read their EMR and interpret information, and having a, if needed, nurse navigator to be able to meet with them to communicate. This is what you may have heard, in answering any questions they didn't understand, and giving the patient and family members the opportunity to help translate and making sure there truly is an understanding in terms of the plan of care. Other things we may have mentioned earlier, but when it comes to discharge planning, making sure that our discharge materials are at a 6th grade reading level, so that we also have the ability to make sure we're reaching those patient populations. And other aspects globally is making sure we're very intentional as our many healthcare folks in regards to medication reconciliation when folks come in, pulling in interpreters with those conversations, and making sure we're very intentional that we don't duplicate up on medications or medication errors.
Absolutely. So really sort of having a wide array of services that can be used by people from all sorts of different places. So Jared, same question for you. Sanford Health is one of the largest rural health systems in the country. So how do you go about scaling these and sort of making sure people in different areas have what they need to combat these issues?
Yeah, so I mean, speaking a little bit about Sanford, so just in terms of the size and scale of our organization, we cover approximately 250,000 square miles across the upper Midwest. So that's approximately the size of Texas across multiple different states, just to give a little bit of perspective there. And in that footprint, we have, approximately 47 medical centers, 200 Good Samaritan Society senior care locations, and world clinics in 8 different countries around the globe. So a pretty extensive network and footprint across our system. We actually have the benefit, though, at least within our ambulatory and acute care settings, to be on a single instance of an EMR. And that was an investment that the organization made really early on, which really helped, I think, pave the way for success for things like scaling different solutions across our footprint. because we don't have to try to manage through different instances of EMRs and things like that with different integrations. But as I think about scaling different solutions, going back to, again, some of the sort of root problems that we're trying to solve, once we've identified the right solution and tested and validated our hypotheses with actual patients, and then refined the experience to the extent that we've removed as much friction wherever possible, the result is that you have a solution that's intuitive and seamless and as simple as possible for anybody to engage with, that really matches people's mental models in terms of how things should work. So, you can imagine a world where, connecting a remote patient monitoring device doesn't require a manual or a set of instructions. There isn't a big convoluted process to search the app store, to find the right app, and then download and go through a lengthy registration process to validate your identity. No disjointed, confusing user experience to navigate, just something that's simple and easy to use. Great experiences make difficult things simple. And healthcare is one of the most complex things around. And so the opportunity for digital to make it simple and engaging can really, truly be transformational. A little bit more practically, one of the big things, though, that Sanford Health has done recently is announced a landmark $350 million virtual care initiative just last year to transform healthcare in our rural and underserved and vulnerable communities across the Midwest by really improving access to convenient, high-quality healthcare, regardless of people's zip code. And so as part of that, we're making sure that we have the infrastructure in place, both from a technology standpoint, but also from just a brick and mortar standpoint, to ensure that people are able to get the care that they need. So the first phase of that initiative really begins with a new flagship construction project for a virtual care center, which will be headquartered in Sioux Falls, South Dakota. And that will be followed with an interconnected network of rural satellite clinics located in different farming communities across the Midwest to really ensure that patients have access to healthcare using some of the most advanced technology possible as close to home as possible. We anticipate that more than 350,000 outpatient visits per year will be able to be provided at home to reach more than 11 million lives, and extending care to more than 275 rural clinics across the Midwest. So really just investing in expanding our what we're already doing in a much more comprehensive way across the footprint that we already have.
Absolutely. And I think that, the level of investment that we're seeing across health systems, just like what you mentioned that Sanford Health is doing, really speaks to how there really is this push to integrate those technologies sooner rather than later. Now, I just want to change tack just a little bit. Roxana, a little bit earlier in our conversation, you spoke about sort of identifying the populations that may be struggling with these digital health literacy issues. So I'd love to hear your thoughts on how organizations can go about essentially pinpointing those populations that really need help.
Thank you. I think it goes to knowing your population and knowing what their needs are, right? So many of our health centers participate in their own needs assessments for their communities. So that's one broad way to do it. But more specifically by patient is really identifying the social determinants of health or social drivers of health that they are facing, and then being able to address those. So there are different software platforms. There's also handwritten forms that many of the health centers have used in the past. Now we're moved into the electronic format, of course. So that information can get collected. So there are some platforms, and then there are some organizations. And Antczak, our membership organization, has recently engaged with one of those organizations that has a very broad access to different other community-based organizations that can inform the patient through the healthcare provider or the staff, the healthcare team, about where they can seek out support. We know that social drivers of health tremendously impact our patient populations. And so we have to recognize that within the healthcare setting, we may not be able to do everything, but we can certainly support our patients and then direct them to appropriate care. So it is also an important part to create a system that allows you to close that loop, to make sure that the care was taken, that the care that the patient needed, whether through those social and community-based organizations actually provided them with what they needed, and closing the loop, making sure that the referral that was made was actually the patient was able to follow up with that, or making some arrangements to handhold the patient to get to that access that need.
Absolutely, absolutely. And Evan, I'd love to hear your thoughts here as well. How does Baptist Health go about finding the populations that really need help? Do you use screening tools? What are some of the ways in which you go do that?
Sure. Yeah. So going back to like what I mentioned earlier with screening the patient when they are qualified for remote patient monitoring, I think that's really, really pivotal. It's about having that conversation with the patient and making sure that during that initial visit that we have a lot of time blocked out to do the education, which really helps combat that digital health literacy. You never want to really assume, I think, when you say you're trying to identify patients that have digital health literacies, I don't think you ever really want to assume that someone based on their age or any of their demographic elements that they will have a digital health literacy issue. I think it's through those conversations that we gain stronger understanding. You could have an elderly retired nurse that knows exactly what to do with RPM technology, or is very familiar with placing a blood pressure cuff or placing a wearable device and knows how to do those things. So, and you can have a younger person who may not be as familiar with that, especially as you look to the rural community. Like Jared, we experience in the state of Kentucky quite a bit of rural communities, and we have multiple markets that is the primary demographic of patients that we're treating in that rural space. I just think it really is about asking that questions, really talking about the program. As Roxana mentioned, we also screen for social determinants of health, and we're very lucky because the module that we use within our EHR system, there's a specific module for that can help us address some of those things and look at social determinants of health. So I think that one big question that you ask when you're doing the screening process and you're identifying these populations is asking about their connectivity, but it really goes beyond that. I think you can ask a patient if you have connectivity or if you don't, but you also might need to go into the home and see what options they have. And what I mean by that is our devices, like some of the other folks on this call and through this discussion, our devices can use cell phone reception. So it might be about taking that device into that space where the patient is and see if there's a cell phone carrier that it will pick up. And our devices are cell phone carrier agnostic. So it doesn't really matter as long as it can ping something, that you'll be fine. And you can look at cell phone carrier maps, but sometimes it's going to take going into the home to establish if that patient is going to be able to use that technology. So it's nice that we don't have to have Wi-Fi or things like that. We can ask that question about connectivity as well, but also just really getting down there and going to the home when you're in the rural markets. And then I think as you're doing some of those screening processes, if the patient has some level of hesitancy, we are starting a marketing campaign at our organization where patients are telling their stories. So putting a video on the tablet and letting that patient who may have been hesitant, that may have that same issue that they're experiencing, talk about how they worked through that. So letting other patients' stories sort of help calm some of the nerves around utilizing this type of technology. I think those are really, really important things that we're trying to do to make this go really well for our patients and set them off with good success.
Absolutely. There's really nothing like that peer-to-peer communication, word of mouth, that can really sort of help alleviate a lot of concerns around new programs, new technologies, and things like that. So, of course, identifying the population that may need support in terms of digital health literacy is, of course, one of the key challenges. But of course, as with any other, barrier in healthcare, I'm sure there are others. So, Jared, would you like to kick things off for us and just discuss maybe some of the other challenges Sanford Health has faced when trying to address digital health literacy issues? And then we can hear from Shireen as well.
Yeah, absolutely. I mean, I think, we've talked a lot about the patient experience. We've talked a lot about these vulnerable communities and digital health literacy. I think, equally important is understanding our clinicians' workflow and the change management process and making sure that we have the operating model that will set them up for success. So, that means making sure that our clinicians have the right tools to monitor and to track trends and to receive, relevant decision support alerts and engage in the right solutions that are already integrated into their existing workflow as tightly as possibly, so that they can respond to patients and intervene when appropriate, and ultimately get the greatest value out of some of these technologies that we have available to us. When I think of our digital strategy at Sanford Health, it's just as important to our caregivers, our physicians, our providers, our nurses, our employees and staff members, as it is to our consumers. And sometimes there's this notion that if we focus on the patient, it must come at the expense of the clinician, or vice versa. And I think that that's a little bit of a logical fallacy. I think there's plenty of win-win opportunities out there that can really benefit both sides of the relationship simultaneously by effectively leveraging digital in meaningful ways. And as I look at digital and the opportunity and the potential that it has to assist and augment and automate tasks for our clinicians, to help reduce burnout, to help make them more effective at operating at the top of their license, I think that there's just a really compelling opportunity to tap into something there. And so, that's one of the other challenges that we have to be cognizant of, is making sure that we're promoting the right solutions that ultimately have those win-win benefits for both our patients and clinicians that serve them.
Mm-hmm. A really quick follow-up for you before we jump to Shireen. So what is your process for really evaluating those devices? How do you go about doing that?
So I loved what Evan said, just in terms of, identifying devices that are potentially low code, plug and play, potentially don't need Wi-Fi. I think, identifying first and foremost, what are our objectives and what are the key results that we're trying to achieve? And then ultimately, making sure that we're very intentional and deliberate about picking the right solutions. And that could include devices that ultimately meet those needs in the best way and accommodate, those different, edge cases around, barriers to entry for people to engage. So, I think having a robust selection process and an evaluation process is key to making sure that you have the right solution, so that you're not, constantly changing solutions, time and time again.
Absolutely, absolutely. Shireen, I'd love to hear from you. What are some of the challenges Providence faced when trying to address digital health literacy issues?
Yeah, I want to piggyback on what Jared just said as well, and those partnerships with the vendors for the devices that we utilize, whether it's our hospital at home program or historically when we were launching COVID home monitoring, or even some pockets of RPM that we have within our organization. Having the appropriate key metrics that you measure with a vendor and the support structures and processes are so important. And I'm not sure if I heard it mentioned earlier, but the other thing is to, when you're launching these programs, you start out with an operational workflow and all aspects of it, but to be really intentional about measuring your success and not assuming you've got it right out of the gate and not hesitate. We do a lot of rapid process improvements, and we may start a program on day one, and by day 3, we've already iterated and optimized it. And so building in the time and space with your operational teams to make sure you're gleaning in all learnings from initial distributions, and whether it be of the devices being shipped out, and or making sure, I think I saw in the chat that we're being really consistent with our processes for educating and having the right languages, materials that we're using for education. And I also think it's important that we survey our patients, our customers, and that we're capturing not only success stories, as Evan mentioned, but also what didn't go well, and what are grassroots initiatives that people out in the field, whether it be our patients or field nurses or command center nurses, encouraging them to offer us suggestions, and having those brainstorming sessions. If you had a magic wand, what else would you add? How would you make this better? And then striving to be able to do that. We may not always be able to go to that exact solution, but that frontline feedback is so important, and being able to get down to really process improvement.
Absolutely. patients or providers can really be the best partners in ensuring that these services are really sort of being as advantageous as they can be. Well, great. We have time for one more question before we wrap up our discussion and jump into some audience questions. So to close things out on our end, I'd love to hear from everyone on the panel, just one or two maybe untapped opportunities for really combating digital health literacy issues within vulnerable populations. So Roxana, maybe we can start with you.
Thank you. So I think some things that we could do that I think we're all trying to do different things. And we also believe in PDSAs, in other words, trying to figure it out as we go, because we recognize the importance of being innovative and being creative. So I think that something that may be untapped is bringing in external partners. I said that a little bit earlier, and that's because I find that we go through these processes to try to inform the patient, educate the staff. We've changed our job descriptions and moved from patient navigators to technology navigators. Those are all useful and effective, but I think that in addition to all of that, it's bringing in external partners and having them understand what we are doing in our health centers or our clinics or our health systems and how they actually can contribute to support that that continuum of care. And I say it that way because I think that we have to recognize that a lot happens outside of the doctor's office, and most everything happens outside the doctor's office except maybe 20 to 15% of their behavior. So we have to really seek out and bring in as many people as possible, and as many organizations and as many people as well, including family members, of course, in our communities, and then get some responses from the community itself. That's also something that we haven't probably tapped into enough. We do focus groups, we do patient surveys, but are we really getting, that's typically feedback and not input. So just kind of looking at it that way, what can our patients and our communities tell us to do in order to inform us so that we're providing them the quality of life that they are really seeking, right? So those are my thoughts.
Fantastic. Jared, can we hear from you next?
Sure. I mean, I think, one of the untapped opportunities that we have in healthcare, I think it's really easy for really any of us, if we were to take a step back and if we were asked to name what is a really great digital experience, we would name, a lot of different experiences, whether it's, your Netflix experience for entertainment or Shopify for retail or Delta for traveling. Very few people would likely mention their healthcare system's digital experience. I think it's pretty safe to say that healthcare lags behind a lot of other industries when it comes to really modern, sophisticated, personalized, sticky digital experiences. And so, the patients who come to us, and we're all patients ourselves, we're the same people who use these other modern digital applications, and we expect the same level of quality in a digital experience for healthcare. And so I think, one of those untapped areas is just looking outside of our industry for inspiration, because it's all around us in terms of how to create a really differentiated and compelling digital experience that makes people want to engage and potentially remove some of those barriers that, digital literacy provides. Another thing that I would say is just the concept of simplicity, keeping it simple. Sometimes, we get really excited in healthcare about that shiny new object that we're implementing, and we continue to add more and more solutions to the mix. But a big part of our success at Sanford with our digital transformation has to also do with what we're not doing. Decommissioning and sunsetting assets that are redundant or not adding value through a strategic rationalization process, and just simplifying our digital ecosystem is just as important as turning on new capabilities and new solutions. And so, one of my favorite quotes from Steve Jobs was when he said, I'm actually as proud of the things that we haven't done as the things that we have done. Innovation is saying no to 1,000 things. And so sometimes we just have to be able to say no on the wrong things so that we can really focus our efforts on the right things and keep it simple so that people can engage easier.
Absolutely. That's a fantastic quote. Thank you for sharing. Great. Shireen, maybe we can hear from you, and then Evan can close us out.
Yeah, I think both Evan and Roxana commented on similar thoughts that I had, really taking the time, as I mentioned earlier, to hear from our patients and our frontline folks to make sure that we're really solving for the right problem and we've got the right workflow. I also like what Jared said in regards to simplification. Sometimes it's also exnovation. We focus a lot on innovation and trying to identify creative solutions, but we need to modernize and streamline our processes. And sometimes that means stop doing some of the things that aren't working. They might be time consuming and or complicating the process in regards to delivering care.
Fantastic. And Evan, what about you? Any untapped opportunities you're seeing in addressing digital health literacy?
Yeah, so potentially community health workers through either state or local agencies. Those folks can go out in the home, educate them right where they are, help them with any other health issues that they might have. Those folks are from the patient's community, so they really have a strong tie back to the folks that live there. So I think that's really important. Also, that concept of maybe like a digital health genius bar, like at Apple, where patients can ask questions when they're on site. So let's say today you got RPM technology provided to you. Now we're going to let you on your way out spend a little bit of time working or interacting with the device. I think that these types of solutions honestly could be full service and offer all the digital health offerings that you have. So hiring digital health navigators or digital health associates that can help those patients sort of navigate those waters. Those are kind of the two things I think. You can have all the technology in the world and you can have the best program, but if you don't have the right people positioned in it and you don't have folks like this that are going to be able to close those gaps for patients, it really isn't going to be as effective.
Absolutely. You definitely need that human touch, no matter how much technology you bring to the table. Well, great. That's a great note to kind of close out our discussion and jump into some audience questions. So we will now move on to the Q&A portion of the session. As a reminder, audience members can submit questions using the text box to the left of their screen. So let's begin with this one. So one of our audience members says, my understanding is that RPM is not available for federally qualified health centers. So are there efforts to find ways to integrate RPM technology in a way to promote better population health and allow for reasonable reimbursement for the practices? So Roxana, I think it would be great if you could kick us off here. And then if anyone else wants to weigh in, we can hear from them.
Thanks. Yeah, so definitely. I mean, what we have chosen to do is to seek out some funding to really train our health centers on the use of remote patient monitoring devices, but also remote patient monitoring services. So what can be done is that remote patient monitoring services or programs can be reimbursed through the CCM, which is the CMS allows for those codes, so that a person can do either transitional care management or chronic care management and be able to be reimbursed in that particular way. So you're basically tracking your patient, but you're using a service which is a third party, and there are several that do this. We found one that is really compatible with and aligned with the federally qualified health center mission and values. So that's how it's being done currently. I think that in the future, we're also using this information to demonstrate as a demonstration project to the state as well as to MCOs that actually, if you are taking care of your patient at every point in the continuum of care, the outcomes are better. Everybody benefits. The health system benefits by reduced costs. The patient benefits by reduced risks and avoiding unnecessary either emergency room or hospitalization or even long-term care facility use. So that helps the health system. The health center itself doesn't necessarily benefit as much as the health system. And that's fine because we consider ourselves part of the community and that continuum of care. So I think that could help answer a couple of questions that were in there.
Absolutely. Does anyone else want to weigh in on this, or I'll move on to the next question? All right, great. Well, we have a ton of other really interesting questions here. So let's jump to this one. We see many patients with low digital literacy are also low income. So how are financial barriers such as a copay addressed when there are costs that the patient may incur for something like RPM? So Evan, maybe you want to kick things off here.
Sure thing. So I think as it relates to this, there's a lot of value in doing remote patient monitoring. And at our organization, we actually do not charge the patient for remote patient monitoring services. There's no copay because we don't bill just yet. That is something that we are working towards as a goal. But I think if you are looking at remote patient monitoring and you're seeing really good quality care outcomes and the patient isn't having as many readmissions and so on and so forth, if you're involved in value-based care contracts, there may be some opportunities there. So that you don't have to, it's the cost is being covered through meeting quality metrics that are already pre-established by value-based care contracts, and you're getting money back for the quality care outcome that you've supplied. So I think you have to get creative with this, and certainly if patients can't afford it, looking to write those things off. If you are, if you do bill for this, finding those vulnerable populations and saying, we're going to use charity care to address this, and we're going to write this one off because this is important enough to their overall picture of health that we don't want to have that barrier of cost.
Absolutely. Jared, I'd be curious for your thoughts here as well. I'll repeat the question. How are financial barriers such as a copay addressed when there are costs that the patients may incur for something like RPM?
Yeah, I mean, my mind immediately went to the importance of, partnering with the payers in this space, right? And making sure that we're aligned in terms of what we're trying to achieve so that we're not creating barriers for especially folks with less resources or lower income to be able to engage. I love what Evan said about, a value-based care contract. Ultimately, that's where a lot of things are trending in this more value-based care world. And it allows us to be a little bit more innovative in terms of, from an economic standpoint, exploring options for leveraging technologies in more meaningful ways and getting, further upstream and downstream from the traditional, encounter-based fee-for-service reimbursement model, because everybody is aligned on keeping people well and keeping costs low and allowing patients to, ultimately be able to receive care, and in some cases in the comfort of their own homes is something that's very attractive and valuable. And so I think that frame of reference really pivots when you start talking about more of a at-risk reimbursement model that really promotes that kind of thinking and operating model.
Mm-hmm. Absolutely. Great. All right. Another audience member asks, do you have an evidence-based screening tool that is an objective measurement of e-health literacy? This audience member is considering the e-heals tool. So just wanted to get your thoughts on that. Shireen, maybe you could field this one.
Sorry, in my role, I'm not aware of one specifically, but I'll certainly take it as an action item to find out if we have one.
Fantastic. Would anyone else like to weigh in on any evidence-based screening tools they're using?
I'm somewhat familiar with eHeals. I've seen a couple of other screening tools as well. I think that they can be valuable in sort of getting a little bit more of an objective screening result. The trick is, getting people to engage and getting people to, answer the questions and to not feel maybe sensitive about how they're responding. And so I really like what Evan said earlier in the dialogue about having a conversation with people. Sometimes when you just give people a survey or a questionnaire, it's difficult to understand how accurate the responses you're getting back are. But having a conversation with somebody face to face and establishing that relationship seems to take a little bit more time, maybe a little bit more resource, but you end up getting a lot more accurate information as a result too.
Absolutely. Absolutely. Thank you so much, Jared. Let's go back a little bit to the reimbursement question. So one of our audience members asked, which you talked about a little bit, Roxana, so maybe you'd like to add to that. But she has a two-part question. One is, what financial solutions are you using to fund RPM in FQHCs and rural health centers? And the second part of the question is, what is your outlook on FQHC, RHC fee-for-service support for RPM reimbursement?
So the first part, I think I mentioned earlier. So what we're trying to do, we're using remote patient monitoring services or programs so that it can be reimbursed to the CCM. So that's the work through for the current situation, especially in areas where there's a huge digital divide and you really have lack of broadband for patient care. So what you're trying to do is use the resources that you have and do a lot of work with your RPM program, to whether it's measuring their peak flow media over the phone or their weight for CHF, potential CHF exacerbation, or a continuous glucose monitoring device that they bring in and then download, and then you get back to them about that. So those are the work throughs that we have right now in order to use remote patient monitoring services to address in real time things that are happening in the patient's home. So regarding fee-for-service, I mean, I just want to mention that federally qualified health centers and rural health centers get paid in a PPS, which is a prospective payment system, or an all-inclusive rate is really what that is. And it's based on each year how much is spent in the health center by the health center for each for the patient populations that are seen, because they're typically going to be populations that are vulnerable and have greater needs and maybe have not had access to care in the past. So that's sort of what the background on why we do not receive fee for service. Now, you can have contracts with MCOs, with organizations, HMOs, PPOs, and MCOs specifically, to negotiate rates to get reimbursed for other things, including RPMs. But that's really at the very beginning stages. And in regards to the future for that, what we're really going to end up doing is getting to value-based care. So we're not going to go back to fee-for-service. That's not really the goal. The goal is really to see how we are seeing patients best within a certain amount, a certain rate, which is currently PPS or all-inclusive rate. But in the future, it will be under the value-based care, which many of us recognize we're not ready for, simply because it does require at some point a risk. And so the health centers, at least, are not all ready for that risk. There are some more sophisticated health centers who have been working with population health and within their own organizations, which may be typically very large and very experienced. And so they can negotiate better rates for value-based care payments. So those are more often exceptions in Texas because, as you may know, we have a very large uninsured population because it's a non-Medicaid expanded state. And in reality, 40% of the patients seen in federally qualified health centers in the state of Texas are uninsured and therefore self-pay. This addresses somebody else's question in the chat that were being asked, how do you address the co-pays that maybe patients are unable to pay? So those would be in federally qualified health centers, we use a sliding scale fee. Every patient is assessed for what they're able to pay, in particular when they are uninsured.
Mm-hmm. Absolutely. Well, fantastic. I think we have time for just one really quick question. And Shireen, I think maybe you could field this one. One of our audience members asked, what are some strategic planning and execution efforts that you would have done differently? So just any sort of lessons learned would be great.
Boy, that's a big question for a minute left in the call. I would say, the biggest thing that we found, particularly I'll reference again the COVID home monitoring program, we were very intentional about learning as we went along. We had intentions with our our volume of care and capacity of what we could initially take care of with a nurse-patient ratio and the devices that we were using. And we quickly found that we didn't have the adequate amount and ratios. And so we quickly pivoted to that. But in that, I think, is also the notion of continuing to think about and obsess about the ease of use of the technology and the distribution process of the technology. And we really focused quickly in the first 2 to 3 weeks to quickly pivot and optimize that. And as we were planning the program, how we intended it to go went a little bit differently, but by having the intention and the culture of learning as you go, and every day even having a huddle, what did we learn today and what can we change for tomorrow, I think is really important to the success of any program that you launch.
Absolutely. Well, that's a great forward-thinking note to end on over here. So thank you all again so much for attending this panel session. Please note we have additional virtual summits scheduled throughout 2022. You can see a list and register for these upcoming summits by clicking Register for Upcoming Virtual Summits under the resource list. That concludes the Remote Patient Monitoring Virtual Summit. A special thanks to our panelists, Roxana, Evan, Shireen, and Jared, our audience, and our sponsors, CareSignal, Current Health, and Tropolo. From the team at the Remote Patient Monitoring Virtual Summit and Xtelligent Healthcare Media, thank you and goodbye.